Welcome to a special episode of Your Mark on the World show. Today we have assembled a panel of experts and practitioners in global health to talk about how we can make strides in global health. You don't want to miss this episode. Stay tuned.
Welcome to Your Mark on the World, bringing you another change maker with champion of social good, Devin D. Thorpe.
Well, I'm excited to be here with this incredible group. Let me just introduce you to all of the members of the group. We have with us, in no particular order, Leslie Kalman, who's the CEO of Engineering World Health, Melanie True-Hills, the CEO of StopAFib.org, Deepak Kapoor, the chairman of India National PolioPlus Committee, Jill O'Donnell-Tormey is the CEO and director of scientific affairs for the Cancer Research Institute. Stefan Peterson is the Chief of Health for UNICEF. Derek Fetzer is the Director of J&J's CaringCrowd. Jack Andraka is a researcher at Stanford. Kurt LaBelle is the President of the Global Health Investment Fund. Bruce Aylward is the Senior Advisor to the Director General of the WHO. Siddharth Chatterjee, whom we hope will join us, is the UN Representative for Kenya from the United Nations. Dean Ornish is the founder and president of the Preventive Medicine Research Institute and is a professor at of clinical medicine at UCSF. This is a phenomenal group of minds with a very diverse collection of perspectives on health and wellness, and I'm excited for this conversation. I want to start with Dr. Dean Ornish. Dean, you have focused a lot of your work on public health, especially with regard to cardiac health. Tell us a little bit about your work and how you think it can and should impact public health and global health. Dean, we need to unmute you. Let me give you a little help there.
I'm unmuted now.
There you go.
I think I have to do it here. *6, I think, is the key. From the secret decoder ring.
Yeah.
So for the last 40 years, I've directed a series of studies showing that how powerful simple changes in diet and lifestyle can be, not only in helping to prevent disease, but even also to reverse it. We were able to show for the first time that even severe heart disease could be reversed. We found that these same lifestyle changes that can reverse heart disease can reverse type 2 diabetes, high blood pressure, high cholesterol. You know, when people get put on drugs to treat your high blood pressure, high cholesterol, high blood sugar, and you say, doctor, how long do I have to take these? The doctor usually says forever. I often show a cartoon of doctors busily mopping up a floor without turning off the faucet. It's like, how long do I have to mop up the floor? Like forever. Well, why don't we just turn off the faucet? And the faucet, to a much larger degree than we had once realized, are the lifestyle choices what we make each day. A whole foods plant-based diet that's naturally low, both in fat and refined carbs, various stress management techniques, including meditation and yoga, moderate exercise, and what we call psychosocial support, which is really love and intimacy. Or to reduce it even further, to eat well, move more, stress less, and love more. Boom, that's it. And we found that these same lifestyle changes could also begin to reverse aging at a cellular level. We did a study that we published in the Proceedings of the National Academy of Sciences with Craig Venter. We found that in just 3 months, over 500 genes were changed, turning on the good genes, turning off the bad genes. Particularly the what are called the oncogenes that promote prostate, breast, and colon cancer just turned off within just a few months. We did a study with Dr. Elizabeth Blackburn, who got the Nobel Prize for her pioneering work on telomeres, the ends of our chromosomes that regulate aging, cell aging. And as we get older, they tend to get shorter, and as our telomeres get shorter, our lives get shorter. We found that we could actually lengthen telomeres, in a sense, reverse aging at a cellular level. Medicare is now covering my program. We partner with a company called ShareCare. Jeff Arnold is the CEO, to create a new paradigm of healthcare. And most insurance companies are now covering our program as well. Aetna is covering in all 50 states, Anthem in all 14 states that it covers, Blue Shield and others, HMSA. And we're finding that we're training doctors and a team of people. They work with a doctor, a nurse, yoga teacher, exercise physiologist, dietitian, and psychologist. And Medicare and these insurance companies will pay for 72 hours of training as opposed to a 10-minute office visit. And we're getting bigger changes in lifestyle, better clinical outcomes, better adherence. 85 to 90% of the people are still following it after a year, and bigger cost savings. We're finding we can Highmark Blue Cross Blue Shield found they cut their costs in half in the first year, and by 400% in the subgroup of people that they'd spend at least $25,000 on. It turns out that overall 5% of the people account for 80% of the healthcare costs. Those are the people that we work with. And the more diseases we look at and the more underlying biological mechanisms we study, the more reasons we have to explain why these simple changes are so powerful and how quickly they can occur. And the last thing I want to say, and then we can come back if there's more time, is that from a global health standpoint, the irony is that the diet and lifestyle program that we're using is the one that people in third world, this is really essentially a third world diet, and yet unfortunately other countries are starting to eat like us, live like us, and all too often die like us. More people are dying today in most countries in the world, including much of Africa, from heart disease and type 2 diabetes than all forms of, AIDS, TB, and malaria combined. And yet it's, it's diverting a lot of precious resources from things that really do require drugs, like AIDS, TB, and malaria, to things that can be largely prevented and even reversed by simply changing diet and lifestyle.
Yeah, great.
And with all this, and the last thing I want to say, and this will be it, is that with all this interest in personalized medicine, it wasn't like we had one diet and lifestyle intervention for heart disease, a different one for diabetes or prostate cancer. We, by the way, found that these same lifestyle changes could stop or reverse the progression of men with early-stage prostate cancer. It was the same for all of them. And I think it's because these different diseases share so many underlying common biological mechanisms, each of which is influenced by these diet and lifestyle choices.
That's great. Now, Bruce, I want to just shift gears a little bit. And
can I come in one sec, Devin?
Sure.
Stefan Peterson, UNICEF.
Yeah, Stefan, go ahead.
It's a very hopeful message from Dean, and I'm joining your program, Dean. But I'd like to say that those lifestyle choices are, of course, shaped by the physical environment and the food environment we live in. And I take myself as an example. I joined UNICEF in New York 2 years ago. And actually the change in physical and food environment, suddenly having meetings on the 23rd floor and no longer walking the staircases and having receptions and portion sizes meant plus 5 pounds in my case. So I'd like to say that much as the individual has something to do with this, we're very much conditioned by the environments we live in. And I think that's where city planning plays in, and the whole sort of lifestyle conditions, urbanization, and the commercialization of food systems. So I think we need, much as sort of we should be working on individuals, we need to work on the environments we live in through regulatory and market incentives, urban planning, and other things. So let's not overemphasize the individual choices. Over.
Well, let me say two things in response to that really quickly. One is, since this is Forbes and a lot of business people will be watching this is the area of growth. The natural foods and organic foods and healthy foods market is exploding, whereas soft drink sales are down 50% in the last few years. So I'm encouraged by that. The second is that we use Zoom, just the same video conferencing we're using here to have this meeting, to create support groups of the people who go through our program so that they can redefine what's normal and healthy and create a different cultural context for them, even if the immediate environment around them isn't yet supportive.
Devin, just maybe to come in for a second on some of the points just raised as well. This is Bruce here. And Dean, thanks for kicking off like that, because some viewers of the program may think, well, what's the bigger relevance? But I think, as everyone on this show knows, the escalating rates of non-communicable diseases are the great epidemic in front of us, and not just industrialized, but developing low-middle-income countries, low-income countries as well. And whereas with communicable diseases, everybody looks at those and says, great, we've got vaccines, we've got medicines, we've got solutions to these. There's a certain desperation when people look at the NCD agenda and burden of disease. And this is what makes the kind of work that Dean's doing and others are looking at so exciting. When you look at this and say lifestyle choices and changes may actually not only reduce risk, but reverse disease, that gets really exciting. And that starts to eliminate some of the excuses we frequently find when we're trying to look at how do you tackle this big epidemic in front of us. Stefan's right on the mark, though, at the same time. Lifestyle choices suggest you can actually make the choices. You're not always in the position to make those choices. Stefan is, of course, right? He could walk 23 flights of stairs.
Bruce, let me just ask you a question, though. How are you able to leverage the polio infrastructure with which you were so familiar in West Africa when you were fighting the Ebola crisis?
Well, the key to the Ebola crisis, one of the most important aspects of it was, first of all, the community engagement, right? The key to Ebola was people understanding the disease, because ultimately it's about behavior change to control that disease. And the polio eradication program, well, most people think of it in terms of the delivery of a vaccine to so many, well over 600 million kids a year at the peak of the activity. What it really was, the incredible thing was the mobilization of populations to be part of that initiative. At the peak, we probably had over 20 million people vaccinating kids against a disease that most of them had never seen and wouldn't see. And it was because you were putting the power of protecting their kids right in front of them, or literally in their hands. And I think one of the things that we took in the West Africa experience, and Stefan will know about this, and Deepak and others from their institutions, was really how we engaged those populations, bringing anthropologists into the initiative very, very early to help understand the behaviors we were dealing with, understand the cultures, and help them work out how to solve it. So that was one piece of it. UNICEF gets a lot of credit for the work on that piece of it. But the other key part of the polio infrastructure is the surveillance network that's been put together. You can't eradicate a disease if you can't see it, if you can't find it. And the polio program has got incredible experience putting in place a disease surveillance infrastructure globally, where often there's very, very little else. And again, with huge support from some of the others on your program here, like Rotary. But that, being able to leverage that, was the second huge piece of the infrastructure of great importance. The third piece, Devin, was actually the ability to coordinate and run the initiative across such a wide range of partners. We had the public sector in there, the private sector in there, every possible flavor thereof. And what we did in a couple of countries, such as in Nigeria, for example, the polio eradication command center was repurposed to run the Nigeria Ebola response, and really bring that power of partnership, power of collaboration to the solution. So those are a few of the bits and pieces that were brought from the polio infrastructure, and lessons more than anything to combat Ebola.
Fantastic. Now, Deepak, how do you see us being able to leverage the polio infrastructure for other areas of the global health? Oh, Deepak, let me unmute you here so you can be heard. Go ahead.
Right. I think in India, we have already begun leveraging both the infrastructure and the experience of polio to routine immunization against all diseases for which vaccines are available. And secondly, to utilize the surveillance network to actually detect children who are missed regularly. Also, to overcome religious preconceptions and misgivings about immunizing kids, and to overcome them using the experience that we've gained through the polio campaign. That, I believe, will be a determining factor in our being able to do it. We are essentially concentrating on two diseases right now, measles and rubella. And the government of India is targeting 2020 is the year by which they will be able to get rid of both measles and rubella. We're working towards it. The target date might shift, but the efforts are continuing, learning from the polio experience.
That's great. I appreciate that insight. Now, Jack, let me turn to you and ask you, what is the key to making social entrepreneurship work to the benefit of people such enterprises are intended to serve?
So I think one of the biggest things with social entrepreneurship, we've seen so many of these ventures come in and they don't have any local stakeholders at any level or didn't incorporate them at any stage of the development process. And I think that you need to have that input from local stakeholders, otherwise you're going to completely fail. And we saw that with this project in Tanzania that I was involved with, where before we were involved with these local stakeholders on this water quality monitoring project, that the project was just flunking horribly. Without that engagement of local stakeholders, you're not going to have success. People aren't going to be interested. There's not that basic level of trust. And so really incorporating that is really key in getting social entrepreneurship to really work in these settings and not have these unintended consequences, and going in without these preconceived notions and rather talking to people and getting their input is really essential.
Derek, let me move to you. What role does business play in public health?
I think it's essential, but I think what we have to really consider too is that there has to be the regulatory framework to allow it to operate properly, right? And so I mean, I'm very much against this whole notion of anything goes, because then basically I think you're going to cave to people's let's call it a very basic level, right? so I think that, you know, there we really have to think about what mechanisms and constructs we use to protect that, right? So, you know, in Jack's case, we're talking about social entrepreneurship, and if they're trying to promote something to do something good, how are they going to operate in an environment where they have to fight against monolithic institutions or companies with huge marketing budgets that promote artificial needs, right? And so, I mean, I'm glad somebody brought up that 50% of the, you know, soft drinks have gone down 50%. But they operate against huge, they operate against huge budgets, and I think that's where the protection could come into place, right? To promote public health. And on the other hand, too, you know, there have to be mechanisms in place that the perpetrators or the detractors of public health have to start facing the brunt of their costs, right? The full brunt of what they're costing society.
Yeah, I appreciate that, Derek. Now, Melanie, how can advocacy be more effective through collaboration?
Well, thank you for asking me that specific question, because as a patient in the cardiovascular space, we're actually work with those who have atrial fibrillation and irregular heartbeat that causes strokes. We have worked with organizations in country to develop collaborations and coalitions, including the Sign Against Stroke and Atrial Fibrillation Task Force, which had 102 organizations around the globe signing on to our charter to be engaged in working with media and policymakers in those countries to try to drive policies around getting people diagnosed and treated before they actually have strokes. Strokes are debilitating or even fatal. Atrial fibrillation related strokes are fatal 3 times as often as other strokes, and we're trying to make sure that people get diagnosed and treated before they have that stroke. So working with the in-country organizations as part of these coalitions, they actually know what works for getting attention of the media and of policymakers in those countries. And so we have found that to be a very effective way to leverage what they do, but working in collaboration, we have developed materials that are used by those organizations around the globe, be they local, country, regional, or international organizations. And so the materials that we have developed have then been translated from English into the local languages and used locally as well. So we get a lot of leverage by being able to do things together and then let the in-country folks actually take those forward, knowing their media environment and their policymaker environment in order to have better success.
Leslie, let me go to you now for a moment. How can creative small ventures be grown to scale? Let's be sure to unmute you.
Hi. Well, I have to say I'm not a small venture person. Engineering World Health, which I am the CEO of, works in public hospitals in very low resource countries. And we work in hospitals that have an absence of working equipment because they have an absence of trained technicians. It's a very different mindset than what the rest of our panel has been talking about. And, you know, I recognize that people may think once somebody arrives at a hospital that public health ventures have already failed. But, you know, people do have motorcycle accidents, they do have pregnancies, they do need maternal care, they do need neonatal care. And when those things occur, people go to clinics and hospitals for diagnosis as well as for treatment. So Dr. Ornish's sound advice about good nutrition, but we work in hospitals that don't have blood pressure cuffs. I mean, so people don't even know if they have high blood pressure that they need to be concerned about. So as a result, my interest is in large public support for public hospitals that serve the most indigent people in very low resource countries, and or support from organizations like Johnson & Johnson on this panel who you know, are capable of sinking, frankly, large dollars into things like training technicians, and then most importantly, continuing to employ them. One of the real factors in the developing world that impedes hospitals is that the local governments or the national governments of those countries don't have the funds to support technicians who keep the equipment running. So they have lots of donated equipment that would be fabulous if it was working, but you can show up at a hospital and there's no working x-ray machine, or there's no working incubator for your newborn. So this is not small scale stuff. This is really requires large public or large private, but universal, international kinds of investments.
So you're saying that to grow your organization, you need government, large. How do we translate your comments into understanding how you grow engineering world health?
Well,
your budget is probably measured in millions.
Tiny millions.
So how would you get your budget to $1 billion?
Yeah, it requires government support or support of large corporations or multinational organizations, development banks, to see that training doctors and nurses is important. But there tends to be, more than tends to be, there is generally ignoring the technical staff that keeps a hospital running. So we encounter over and over again folks who are willing to train or retrain doctors and nurses. And as vital as that is, if they're 21st century doctors and they're working with 18th century equipment, it's a waste of resources.
Yeah.
From a UNICEF perspective, I don't know if you guys remember last time your child had a fever and what you did and where you went, etc. So we find in many low and lower middle income countries, and why not even a high income country, the question is what is available within the first mile health system from your house. And chances are that it won't be a hospital. So we're in fact working very much with the community health workers, or what we like to call more agnostically frontline health workers, because it could be a private clinic or a private pharmacy as well in many of these settings. However, those nearby resources need to be backed up by a functioning primary healthcare system. And that's where your hospital comes in, Leslie, as a referral chain after the health center has exhausted its resources. But conversely, it's also about going the other way. That hospital or that health center supervising that frontline health worker, supporting them and making sure they have that equipment. So I think it actually takes a functioning system, and that's going to be, I think these days, not entirely a public system. It's going to be a mixed market system, but it needs to kind of come together in one information system and under one planning an overview. And I think the universal health coverage agenda that Dr. Tedros is now championing from WHO is an excellent chapeau for this. But we need to realize that we need several components: the frontline health worker within the first mile, the health center, which is going to be within a few miles, and the hospital where Leslie's equipment is dearly needed when you need that referral to be functioning. So it takes a system.
Right, absolutely. Couldn't agree more. That's right.
Fantastic. Well, let's go to Jill. Jill, how does research figure into the formula for improving global health? Oh, let's unmute you here. There we go.
Yeah, so obviously from my perspective at the Cancer Research Institute, we're all about supporting, fundamental discoveries and translational research as well as some clinical research. So it's way at the other end of the spectrum of what many of our other panelists have discussed. So I do think, we think about delivering and services which are critically important, but bottom line is the basic understanding of biology and mechanisms and understanding disease and how you treat it is where everything begins. And without that, I feel, we don't get to deliver anything if we don't know what we're doing. So I think the real key, a primary need is sustainable research funds. As I've always said, as a not-for-profit and you're raising money to do cancer immunology research, many people say, well, how much money do you need to cure cancer? And, that's a question that I always say, you can't put a dollar amount on. Science doesn't work that way. Science isn't linear. I can't just say, give me this amount and we're done. You need to train generations of scientists. You want excellent research, you want inquisitive minds, and you want to give them the ability, the training, and the resources that they can ask questions and carry their research on. And there's no time limit to that. So I think bottom line is sustained sources of funding for research, which comes obviously many times from government, it comes from industry, and it comes from not-for-profits. And I think more and more we're seeing more collaboration among these three groups in terms of how to do it. But again, it's how do you streamline it? How do you not be redundant? How do you prioritize things and keep the entire system going? Because we need, obviously, to attract young people to science. We need to train them, and we need to, they're the future of the world in terms of what we're doing. And, science has become a very, at least in the United States, it's support from, NIH and NCI, which is the backbone of our biomedical research system, is under stress. And so we need to find new ways of raising money and supporting it and
we also need to change the concept of research. I'm a recovering academic myself. I was a professor at the Makerere University School of Public Health for 3 years in Uganda. And the line of research we pursued there is actually what we call implementation research, which is about fixing the system. Actually get what is it that keeps Leslie's machines in the hospital from working and the technicians from getting trained and being in place. So that's sort of the non-glorious, non-discovery type of research which can actually fix systems. And if we can build that as a natural part in the implementation, so that we just don't wait for the airplane to crash and then conduct a thorough end-line crash investigation, but we actually use and build in instruments in the airplane and we figure out ways, short action cycle research to fix the system and implementation as we go along. And I think that's sort of, when I was a university professor, that's the kind of research you didn't get promoted on because it's not promoted within academia and it's not the natural part of the implementation programs we do. I think business might do this better. You can't afford to have your delivery and marketing system fail, even if you have excellent product innovation. So I think you're much better at the whole value chain, and I think we need to change the concept of research and its funding to actually achieve that also in public health.
On top of that, I'd just like to add that in getting these funding to research, we really have to focus on combating this graying of science, where we've seen the average age of someone receiving their first NIH grant go drastically up. I think it's around 40 right now. And so getting those young career grants is really essential for creating this pipeline of researchers that Joel is talking about and getting more people involved in this type of global health research.
That's a great point. Now, let me ask you, Kurt, a lot of what we've talked about today so far is activity going on in NGOs, government activity, other nonprofits. You're investing for profit in this space. What are some examples of the investments that make sense for you as a for-profit investor. Oh, let's unmute you here, Kurt. Let's see here. Kurt, okay. Kurt, try it now. No, you're still muted here, Kurt. *6 on your phone, or if you're still online that way, or
all right.
There we go.
Is that working?
Yeah, that's working. Go ahead.
Okay, yeah. So I run the Global Health Investment Fund, and as you mentioned, we are a for-profit fund, but we're a double bottom line fund. So we're trying to generate positive returns for our investors. But every investment we make has to serve a clear need in the developing world. And so if we can't check both the impact box and the potential for revenue generation, then we can't make an investment. And I'd like to echo a lot of what I've heard today here. I think there have been a number of good points. Every investment that we make, we have to evaluate not only is it an innovative product that could serve a need in the developing world, but is there a way to actually get it to the people who need it? And that involves so many things, from the people on the ground, the caregivers, to the distributors in various countries, to the NGOs who can help facilitate a lot of this, the regulatory authorities that need to set up a framework. I think Derek mentioned that earlier. And understanding all of that is incredibly complex. So you need all of these pieces essentially to be in place. But our goal is to take innovative products, and these can be vaccines, these can be pharmaceutical products, these can be medical devices or medical diagnostics, and get them to the people who can benefit the most while generating positive returns for our investors. But that means that if it's going to get to the people who really need it the most, it has to be simple to use. We do not invest in things, I think it was Leslie who earlier was saying that they go into centers and they see nice equipment, but it can't be repaired. So we do not make investments in things that require a big piece of capital equipment and someone who can repair it and keep it up. We will not go there. But we also need things that have a regulatory framework. And I'll give a couple of examples, Devin, that I think really come into play here. One would be that if you look back at snake bites, which surprisingly kill about 100,000 people a year still, one of the main reasons for that, especially in Africa, was that there wasn't a regulatory framework. No one had established requirements for these antivenoms, and what resulted was a lot of low-quality producers who would make these things available at a low price. Various countries and entities would buy them, but they were of such low quality that they didn't benefit the patients who received them. What has started to happen now with the leadership of groups like the Kofi Annan Foundation and the WHO is they're establishing requirements so that manufacturers can produce a quality product, that the buyers can know that it is a quality product, and organizations can work with the purchasers to put in place a framework whereby they commit to only buy from qualified manufacturers. So that does a couple of things. It helps the patients because they will only be getting a quality product, but it also provides an incentive to the manufacturers where they know if they do produce something of a high quality, that they won't be undercut in price by a low quality product. So that's, I think, an example of how you need these minimum requirements and regulatory involvement. And we've backed a company that's developing an antivenom, which we're really excited about. Another one is you need something that is, as I mentioned before, inexpensive, easy to use, doesn't require years of training to learn how to use it. And I think an example of that we've worked on recently is a simple handheld device that can be used for cataract surgery. And cataract-induced blindness is the biggest cause of blindness in the developing world. And cataracts, we know we can address them, but one of the big problems has been that it requires years of training for the physicians to learn how to do it. The best equipment for it historically was phacoemulsification, which costs $50,000 to buy and $200,000 per procedure for the disposables. So the training required and the expenses involved just made it so it wasn't feasible. So all that's been done to date is you get some of these docs from the US and Europe and elsewhere who will kind of parachute in, do a bunch of cases, and leave. We looked at that and said we need something where these local doctors can be trained in a short period of time, and when the trainers leave, that skill set stays. And so this device that we've funded with EonTech does that. It's a small incision. It can be learned in a couple of days, so that skill set remains. And we also love that because it serves a need in the developed world where you can have bigger profit margins because it uses no energy and gives a result that's on par with what you see with the gold standard phaco. So those are, I could go on with other examples, but hopefully that gives you a good feel. Yeah.
Great example. Let me, Derek, did you want to add something?
Yes, I did. Thanks. Because we were talking about the allure of business, of course, is to make it sustainable. And I just wanted to interject and just kind of build on the prior comment that right now things are set up to treat disease, solve conditions. And so that's where business focuses on, what it's focused on. It's not really focused on perpetuating good health, right? And, I think that's where some of the conversation is going over the last hour. And in order to perpetuate that health and build up that environment and that landscape, that's where we have to start looking at the creative use of funds, social impact bonds, and things like, in the environmental world, you have carbon credits. Why couldn't we have public health credits or sugar credits or something to the effect? But building something towards that you can tap into as you perpetuate health. And that's where the business community could come by and say, work with government, with regulatory, and say, we need to come together to create the incentive to perpetuate health.
And Devin, just to come in on that excellent point just made, if I might.
Please, Brad, go ahead. Go ahead.
Yeah, it's first, but it's so much of the discussion so far as we've talked about, strategies and a way forward on the challenges facing global health have been within the health sector itself. And one of the points Derek spoke to, and I believe was alluded to by Kurt as well, was the real big solution, the real big gains, many of them are outside the health sector, actually. If you want to prolong lifespan, you're going to do that with some very savvy investments outside the health sector. It's going to be in education. It's going to be in water and sanitation. It's going to be in food sector, occupational health, and places like that. And so as we look at a strategy on tackling global health, you've got to be looking at within the health sector, obviously, but also the determinants of health. And, historically or most recently, people have been referring to these as the social determinants of health, part of the economic determinants. But an interesting phrase recently has been the commercial determinants of health. And that gets a little bit, Derek, to what you were talking about. Commercial interests probably have a bigger impact on our health than any of the other ones we've been talking about. And this is a really, it's part of the challenge. If good health is, longer lives, longer disease-free lives, you've got to work right across that spectrum. And that gets really, really tough. Derek made a couple of really salient comments about that in his last intervention, not the most recent, the one before, that may have just slipped past as we weren't focused on them. But those are the big ticket ticket
This is Dean. Can I build on that for a moment?
Yeah, go ahead, Dean. And then we step up.
I think that one of the biggest misconceptions is that lifestyle changes are prevention. It takes years to see the benefit, and because of that, why should I spend my money today for some future benefit that some other company, whether it's another corporation or another insurance company, is going to get? But that may be true with primary prevention. But when you're talking about using lifestyle to actually treat and even reverse the progression of the most common chronic diseases, the economic benefits accrue in the first year. We did a demonstration project with Mutual of Omaha, and they found that they saved almost $30,000 per patient in the first year because under their doctor's care, most of these patients were able to avoid having the bypass surgery, angioplasty, or stents that they were told that they otherwise would have needed. We did a demonstration project I briefly mentioned earlier with Blue Cross Blue Shield Highmark of Pennsylvania, West Virginia, Nebraska. And we found that compared to a control group matched for age and gender and disease severity, that they cut their costs by 50% in the first year and by 400% in the first year in the subgroup of people that they'd spent at least $25,000 on in the preceding year. And as we move more to the kind of value-based and not just volume-based economics, accountable care organizations, integrated delivery networks, or just the fact that most large corporations are self-insured, these savings accrue directly to their bottom line. So there's not only the right thing to do, but there's an immediate economic benefit as well.
Those are powerful numbers, big incentives.
My point is to say that this actually needs to start already at conception. And so the best advice to an unborn child is to pick your mother well and make sure that she's healthy and has a good pregnancy. And it carries on from there. And I think the world now, South Asia is in the midst of a youth bulge and Africa is yet to go there. So those determinants and investments that Bruce referred to, they really need to be made in these young generations now, in terms of health, in terms of education, so that we actually have productive members of society. We know there are unproductive things you can do with your life as well. We see that on the news every day. So I think as the world, we need to invest in this coming generation and do it early enough. We need to respect this through good marketing of dangerous things to actually young kids, and we need to make healthy choices, easy choices. It's important for these people, their participation in society, but they're also future customers. And I think smart companies have actually realized this, that it's low and lower middle income countries which are growth markets. And let's make sure that we grow those markets and we have productive members there.
Jill, I want to ask you a question.
I'm sorry.
Go ahead.
Could I butt in for just a moment? Just trying to enlarge the ambit of this conversation. I think we are perhaps, and rightly so, stressing on the supply side. We are not paying as much attention to the demand side, especially in the third world countries. And given our experience in India with the corporate social responsibility initiative, where a lot of corporates are trying to build up demand for these services which are available. When you have religious mind roadblocks and you have other issues about being scared of a needle or a syringe, that is where they have a very vital role to play, the NGOs as well as the corporates.
But one of the interesting things, Deepak, if you go back and read through all those great comments that many of you sent in beforehand to Devin, one of the very few common threads through every single one of them is all about that community engagement, that local ownership, leadership. It's the recurring theme. I do think the world is starting to get that. I don't think we're really good at it yet, but people are getting it. And thanks to your organization, Deepak, for what you guys have done, and UNICEF for really being there with you on it.
Something in UNICEF, we used to talk about demand generation, but we've actually banished that word. We talk about social accountability now. It's a two-way street.
Interesting philosophy. Jill, I want to ask you really kind of the hard question here. How do we go about making it so that in 30 years, cancer is not a problem we worry about? What do we do over the next 3 decades to make sure that our kids and grandchildren just don't think about it? It's just not a problem. Here, let me unmute you here. Sorry, Jill.
Who's on now?
Okay, there.
Jill? All right.
Yes,
Jill, you're good. Go ahead.
Okay. Well, very tough question, especially whenever you put a time length on eradicating disease and not worrying about it. And obviously there are things, I always look at it that we need to understand the biology better. I think, in the field that we work in cancer immunology, there's been an amazing revolution over the last 5 years of, I think, conceptually, I think the medical community believes now that the immune system can be used to treat and control cancer. We are seeing some remarkable durable responses with some of these checkpoint blockades that have been approved by the FDA and other regulatory agencies around the world, but it's only a minority of patients that are truly benefiting benefiting in this long-term world. So I think we have to figure out, the biggest questions now is how do we make these remarkable changes when you can capitalize on your innate immune system? How can we make this something that affects all patients and not just a subgroup? So I think, again, I sound like a broken record, but going back to the biology and mechanistic understandings are extremely important. Then, of course, there's certain lifestyle things that are certainly, we know there are preventable diseases. There's a large percentage of cancers are due to viral causes. Vaccines can be developed for those. And then, as everyone's been talking about, there's certain environmental factors that certainly lead to cancer progression, and that requires public education and awareness. So I think, I don't think it's any one of these things alone that you're going to say is the magic bullet that's going to, make us not think about cancer, but we needed, a complex, multi-pronged approach to how we deal with it. And I think research is an important part of it, but also public education is. But I think we need to understand, again, I go back to, understand the biology, to understand what are these environmental factors and what do they do, and how can you make, solid public health recommendations on what to avoid. But again, we want to make sure that's all based in science.
And this is Dean. Can I build on that for a moment?
Please.
So I love the high-tech approaches. They can be life-saving. If you've got a particular type of melanoma and they can develop a targeted immunotherapy towards that, it's awesome. At the same time, I want to emphasize that the major cancers that afflict us, prostate, breast, colon cancers in particular, are directly linked to the lifestyle choices that we make each day. And we did a randomized trial with Bill Fair when he was chair of urology at Memorial Sloan Kettering Cancer Center, and Peter Carroll, who was and still is the chair of urology at UCSF, where I'm a professor, finding that these same intensive lifestyle changes can not only help prevent, but even reverse the progression of men who have early stage prostate cancer. Slow, stop, and even reverse the progression. Now, this is coming at a time when, if you look at prostate cancer, a large randomized trial last November in the New England Journal found that after 10 years, men who were treated with surgery or radiation really didn't live any longer than those who did nothing. And yet most men don't want to do nothing when you have a tumor growing inside. So they're more likely to undergo these procedures, which often maim them in the most personal ways because they're often incontinent or impotent or both, and only maybe 1 out of 50, if that, really benefit from it at huge economic and huge personal cost. At the same time, if it's true for prostate cancer, chances are it may be true for early stage breast cancer as well. So what I'd like to see are more good, well-funded, randomized trials looking at the effects of these intensive lifestyle changes. And several people have talked about the mechanisms that we need to study, which I completely agree. But what I'm struck by is how so many of these underlying conditions, not just prostate, breast, colon cancer, but heart disease, diabetes, and so on, share certain underlying biological mechanisms like chronic inflammation, stasis, apoptosis, angiogenesis, all of which are directly affected for better and for worse and very quickly by the lifestyle choices that we make each day. So I think that we shouldn't underestimate. I was at a large cancer meeting last year at the Salk Institute, and the first speaker, who's a noted cell biologist, said, we used to really think that cell biology was going to save us all. She said, what's really powerful are lifestyle changes. And so I think finding the right combination of both is really ultimately what's going to make the biggest difference.
Interesting insight. I appreciate you adding that to the discussion. Leslie, I wonder if you would just comment on, from your perspective, the sort of the broad ecosystem that we need to foster in order to create health. It isn't just about disease, but it isn't just about blood pressure cuffs. How do all these things come together to make this work?
One of the things I think has been touched on but not really emphasized is the education of women and girls. I think, just as clean water is vital to public health, so is the education of women and girls for a whole range of reasons, pretty much touching on everything we've talked about. And I think if we think about broad public health measures, getting girls to school, we talked earlier about selecting the right mother. The right teenage mother should be educated and hopefully not have too many children in her teen years. And I think everyone on this panel understands the importance of prenatal care and fewer pregnancies and ending child marriage, ending forced marriage, the whole range of things that go to women and girls. So I'd like to insert that into the conversation.
Great.
Of
Derek,
all the different things we've discussed, Devin, so far, Leslie just nailed it, right? If there's a single intervention that's going to have the single biggest impact on both longevity, but also disability-free life years, that's it. Educate the population, the right part of the population as well. So thank you, Leslie. Nailed it.
Derek,
I want to interject. I completely agree with that. And, it sounds reminiscent of what Muhammad Yunus did with the microfinancing and in Bangladesh. And also on our own platform, CaringCrowd, a lot of the projects we see coming and get funded very quickly are women and children education projects.
Excellent. Now, Kurt, I want to ask you, you invested in a company called PATH, I understand, that provides deworming drugs. How does deworming help kids? How does it impact them? And how does your investment help scale that up?
Yeah, so it's a great question. Are you able to hear me okay, Devin?
Yep.
Okay, excellent. So, yeah, that's a program. It's actually a very interesting investment that we made. We're collaborating with PATH. We're also collaborating with Swiss Tropical Medicine. And we're taking a drug that was actually developed in China. And as you mentioned before, targeting soil-transmitted helminths, so hookworms and roundworms. And it's a massive problem in the world. Over 1 billion people get infected by these. It can be oftentimes quite debilitating, drains people of energy. Depending on the exact reaction, you can get all kinds of manifestations, but it prevents children from going to school, really affects the family in a massive way. And the drugs that are out there that are used today, there are a couple that are used in mass drug administration programs that are administered by some great organizations. But one of the big concerns that they have right now is that eventually, as they've seen in some of the veterinary applications of these albendazole and mebendazole, you start to see some resistance. So they want to have more drugs that are in the cycle that they use for these mass drug administration programs. And this is one that has been used in thousands of patients, and we have good data on it. And we are funding some additional studies that will be done to international standards to prove that this drug called tribendimidine can work as effectively or more effectively and then be introduced into that cycle of these mass drug administration programs. Which we're very excited about. As we look at our portfolio and just the raw numbers of people who can be affected and whose lives can be improved by this, this one is probably the most impressive on that front, on the impact front. You might then ask, well, how do you ever make money off of that? Because these are generally drugs that are donated or sold at extremely low prices. And one of the ways, and I think this is something that is a good program here in the U.S., is it's through a priority review voucher program. So the FDA has set up a program whereby they said, we want to encourage research and development for neglected tropical diseases, and soil-transmitted helminths is one of those. And they said, look, if you develop a drug and get it FDA approved for one of these indications, and they have a list that you can look up, not only will we review and give you feedback and an approval or not within 6 months on that drug, but if we do approve it, we will also give you a voucher that you can use to have another drug of your choice reviewed within 6 months. So it's a priority review voucher. But the interesting thing is that you can sell that voucher to anyone. And what we've seen over the last few years as these vouchers have been sold is that big pharmaceutical companies and biotech companies that have what they think is a blockbuster drug will pay $100 million plus for the voucher so that new drug, that blockbuster they have, can get on the market a few months earlier than it would otherwise. And so we actually have a couple of drugs in our portfolio that are hopefully going to qualify for a priority review voucher that we can monetize. But what's interesting, we think, and it's an example of what we require out of every investment, is we require global access commitments from every investment. And that means that the companies need to make their product available at a low price, and they're legally committed to this as part of our funding, to the developing world. They can charge whatever they want elsewhere, but we tie them down to specific costs that are feasible for low and middle income countries. And for these priority review voucher programs where there really isn't a market, what we've done is we've set aside a certain percentage of the proceeds that would come from the voucher to actually manufacture and distribute the drug so that it gets out there to those who need it the most.
Fantastic. Now, Melanie, I want to just come back to you for a second. I wonder if you would just tell us about some of your big wins at stopafib.org and some of your biggest stumbles and how you've learned from those. What are the lessons you take from those experiences?
Well, Devin, we have had, I would say that our biggest wins have really been around the ability to leverage our work with other organizations. For example, we have a collaboration with the American Heart Association where we have created a website for educating people globally about atrial fibrillation and the risk of strokes, and have fortunately had underwriting of that resource by Janssen Pharmaceuticals. And so these kinds of collaborations where we're working together to drive much bigger projects for organizations such as mine, because stopafib.org is really a very small organization. There are only 3 of us. And so we have to have the leverage that comes from collaborations with other organizations. So that's an example of the kind of thing where we've had some big wins. We've educated people not only in the U.S. but around the globe around this whole issue of atrial fibrillation, which for those who are not familiar with it is an irregular heartbeat that leads to strokes. And certainly as we get rid of problems in the developing world such as childhood and maternal mortality and deaths at younger ages, we're going to be seeing more people being subject to the NCDs, the non-communicable diseases. And so we're focused on education around that whole area so that we have people aware of these kinds of diseases that also can lead to early mortality. As far as some of the challenges or lessons that we've learned, I would say that politics is certainly one of the regulatory environment, and politics is certainly where you run into challenges. And in fact, our biggest challenges have been actually in the United States, not in other countries, where we've run into total roadblocks with U.S. Congress being gridlocked. So we've not been able to have the traction that we would like to have. We've done things like get National Atrial Fibrillation Awareness Month in September declared, but some of the other things we've tried to do through Congress have been much harder, and we've actually had bigger successes in other countries with their policymakers. Many of them seem to be much more open towards policy changes, and that's where we've had greater success than even in the U.S.
Well, I appreciate you sharing that. It's, I think, helpful for this discussion. Let's see, Deepak, how can we make individual health initiatives into people's movements?
I think the best example of that, and Bruce would perhaps underscore what I'm saying, has been seen in India and currently in Pakistan, where the coming together of the Muslim ulamas with NGOs and the mainstream health movement have helped overcome a lot of roadblocks to immunization. There have been a lot of rumors, there have been a lot of misconceptions about the vaccines being some kind of a tool for some other nefarious purposes that have been overcome very successfully by the involvement of the Muslim teachers in these particular areas in the country. I think that is a striking example of how demand-driven or demand for healthcare, where the community demands it, becomes such a major issue. Today, you know, in India, we find a lot of mothers tell us that because my child sees a health worker wearing a yellow apron, he or she automatically opens his or her mouth because they're expecting polio drops to go in there. So it's really entirely a people's movement which can get such a massive job done.
No. Thank you, Deepak. I appreciate that. Jack, I want to come back to you for a minute and this cancer question as a follow-up to our conversation with Jill a little bit. But when you were a young teenager, not that you're old now, but when you were a young teenager, you invented a new process for cancer detection, for pancreatic cancer. As you look out into the future, what's your take on where we'll go in terms of this fight against cancer over the next few decades?
I think one of the most important things that's probably happening right now is this kind of big data movement that's going on in cancer with machine learning, as well as all these really interesting biomarker discovery processes. And I think that's going to be really elucidating in terms of first getting better diagnostics very early on, which is really great at if you can't prevent the cancer, that at least you can detect it early when treatment is first less expensive, but also way more effective. And we could really see that with pancreatic cancer, where if you diagnose it early enough, you have close to 100% chance of survival, and you don't have to do things like the Whipple resection, which have huge mortality rates. And so getting that early detection through these increased studies on biomarkers is really key to addressing the cancer problem. And on top of that, investigating these kind of new branches that are coming out. So looking at your microbiome inside your gut and looking at these unconventional ways that are beginning of treating cancer that are beginning to kind of emerge. And the diet kind of plays into managing that microbiome, as well as looking at all these new kind of next generation sequencing things to get a better understanding of this process, as Joe was saying.
Now, let me ask you, Stefan, to comment a little bit about what Leslie raised in terms of women and children and healthcare. You've been at UNICEF focused on this for a while now. What are the keys to improving health for women and children around the world?
I think Leslie nailed it already. So in fact, I have little to add there. The question is, obviously, it's the life cycle approaches we've been talking about. How not having a teenage mother or a child mother actually sort of is really key if you're looking at the prevention aspects there. And then having a healthy pregnancy, and then having a respectful maternity care delivery with good quality, which means that that staff member who is there needs to be able to wash her hands and have all the drugs and implements, etc. So it's actually taking a systems approach throughout the life course, and education is not the least important in there.
It does, if I may, it does speak to the issue raised earlier too about social impact and broad societal desire to see girls not be married, whether voluntarily or involuntarily, to prevent pregnancy among girls under the age of 17, which we see all over the world, and to have community support for girls continuing to attend school, even if they are, for instance, menstruating. And so you may need to think about sanitation at a school building. Girls often will not go to school if they can't deal with the fact that they're menstruating at that time, or they are prevented from going to school. So, these women do in fact hold up half the sky, even though it was Mao who said it. And recognizing their importance to development overall is something that is still too much in the future. And
Leslie, that's very much our everyday discussions here at UNICEF, because we're not just in health, we're in education, we're in WASH, and we're in communication, etc. To actually convert what you say now into programming together with governments and with private sector, which holds a key to many of these things. This is not I know Johnson & Johnson, for instance, you've been innovating in the field of recyclable menstrual pads from banana fibers that were otherwise thrown away, etc. So I think that it does take action in this field.
But a lot of this, Devin, also comes back to that question that you asked Deepak earlier. How do you take some of these initiatives and really change them into the kind of social movement that's going to be needed? Because, Leslie, exactly what you said there, to get some of those changes that you're talking about requires a societal movement behind it. And that means getting from, the awareness, getting past just being engaged in, whether it's delivery of polio drops, whatever, to really feeling ownership of the outcome that you're driving for. And that is the key. And I think we speculate a lot about why things move from initiatives to movements, but I don't think we're really good at that yet. I don't think we've really understood yet how to harness and achieve some of those changes, which are so fundamental to the kind of going to scale on a lot of what's been discussed here today. But I think if there's one thing we can look at and study, it's a little bit how Rotary over 20 years has gotten tens and tens and tens of millions of people engaged in a movement to prevent a disease most of them have never seen. It's spectacular. So much to be learned.
Thanks, Bruce. I want to ask you as a follow-up, you've been working in public health for a few years now, and
Just a few. Yeah.
You started your career, as many would, in the field. And I wonder how your field work in the early days of your career informs your work today at the senior levels of the WHO.
It's I think absolutely essential, and I think one of the challenges we have in so many organizations is that in our senior leadership teams, you very rarely have people who have actually worked at all the levels of an organization, and especially at a local level. And Devin, just to go back over the last couple of years, at a certain point, I was asked to step in as the special representative and drive the Ebola response in West Africa. And I spent most of the last 18 months of that initiative on the ground in little villages across West Africa and driving huge, I don't know how many times I drove between Freetown and Conakry, but it really was absolutely critical to ground truth what we were working at the higher levels to support. So I'm a bit of a fanatic on that, and I'm known for that. But I think one of the things that I took away, again, from the Ebola experience as well, is just how talented the people at the local levels are in dealing with the challenges that they face. And you kind of have to go there and see that again and again and work with those communities and almost get like, wow, these people know how to do this. These people can find the solutions. And so I see it as absolutely fundamental. There's got to be the right balance, of course, but I find that experience has been invaluable to me on a day-to-day basis. And, today we have a new Director General at WHO, as most of you know, Dr. Tedros, and what he's gunning for over the next 5 years is that we are measured by the measurable difference that we make in the health of people at country level. And if you want to be able to connect what we do here in Geneva all the way out there to the field, you better have a sense of what that looks like, who's out there, what their problems really are, and how the solutions might be, how you might put the solutions in their hands to the solutions they want to be able to address them. A little bit long-winded, but a super important issue.
Thank you.
Stefan's experience is I've worked in the case of Uganda, both in the Ministry of Health and in local academia at Makerere University. And I think that's really shaping everything I do daily. But it's also taught me that actually the local action is very important, but that we need to create conditions where there are incentives actually for local academia to get together with local policymakers and practitioners and define issues and see what they can do together. One thing that does hamper me, though, is that most of my experience has been in relation to rural healthcare, and that's the picture I carry around. Yet half the world is now urbanized or peri-urbanized, and that's not my mental picture. So I think for good and for worse, we carry those pictures with us. So I'm looking actually now to find people who come with that urban health background and who can help me think that way.
Yeah, and one of the points just made by Devin, sorry, Jack, Devin just made by Stefan, I think is so important. It's not good enough that you did it 30 years ago, or like, when I started my career, those few years ago, or a few decades, in fact. But it's really, you got to go back. The world changes, and I tell you, these places are changing so fast. What mobile technology has achieved and the access there, and the expectations, the information, it's a completely different world, and the areas are different, the cultures are different. And it's not like I did this 30 years ago. Not good enough, and you're not respecting and really trying to understand the people that you ostensibly are seeking to help. Jack, sorry, you were going to jump in.
I was just going to jump in and say that one of the big problems, at least that I face when I'm doing my work, for example, with the water quality in Tanzania, was that we were running into this consistent inability to actually collaborate with these academics or nonprofits to create that connection because of a fundamental lack of data. Because there's this really interesting article published, I think like 2 years ago by Morton Yervin that kind of elucidated this, where the vast majority of development data is either out of date or you're trying to like do some statistical magic to get to like work in between these periods where you don't have data. And so I'd really encourage an increased focus on solid data collection, because a lot of our data systems are really poorly crafted right now. And so expanding our data collection capabilities and increasing funding for increasing those capabilities is really key, because right now that makes up 0.1% of development budgets is going into statistical capabilities.
Now, go ahead.
I'm so sorry. As I mentioned, I just found out that one of my family members has pancreatic cancer, and just found out that he had been in remission for a couple of years, but it may be progressing now. So I have to go with him to the oncologist, so I have to sign off early. But wanted to express my appreciation and admiration to the fellow panelists, and would love to be included in the future. So thank you.
Thank you, Dean. Appreciate you're taking the time to be with us today.
Take care.
And certainly, Dean, we wish your family and friends well. Jack, I appreciate those comments. Bruce, I wonder if you'd comment, because I know that WHO has some data. How do you react to Jack's feedback on data collection?
We have some real data issues as well as data, and I think as some others may be well aware. We are, of course, a member state organization, and we're made up of 194 member states. So the data that WHO holds is not actually WHO data, it's member state data. And so one of the big things that we've been working with, and here the Polio initiative was really a bit of a trendsetter, a groundbreaker, let's say, and we were able to do this again in Ebola, was to try and open up that data and get agreement and establish mechanisms to get agreement with the member states that we can make those data available. Again, I think, Jack, you may have made this point, but make them available also responsibly. We can sit on a huge amount of case-based data, I mean, on hundreds of thousands of people who had paralysis in the case of the polio program, just as an example. And but you want to make sure that those data are made available to responsible researchers, because they're massive data sets. And these things you control these data and come up with all sorts of ridiculous and unhelpfulness necessarily conclusions sometimes. So what we are trying to do, and I think we've had some really exciting breakthroughs on the polio data, and then we were able to use them also on the Ebola data, is to help get those data into the hands of others that can actually bring the power of their research, their models, their knowledge to actually investigate the things that we need to understand. In the case of Ebola, we got just extraordinary support for some academic institutions and other groups around the world. Also, there are a lot of capacity like that in the private sector that very few people realize, some real powerful research and analytic capacity. So again, we are a member state organization. We have access to a lot of data. We don't own those data. And what we're trying to do is establish mechanisms where they are part of what contributes to that big data, so to speak, or some of that big data that hopefully going forward holds some of the clues to some of the problems we're tackling. It's a tricky one.
Going off that.
Sorry, as UNICEF, we actually collect data in addition to the kind of data that Bruce referred to. The issue is that the kind of data we get typically comes either from health facilities, patients' cases in health facilities, and it does not reflect the people who did not come to facilities, or it comes from population-based surveys, which typically have their sampling frame, as we say, in the last census, etc., and therefore typically misses people who live in urban informal slums and are totally hopeless when you talk about population movement. So in fact, we're also working with private sector and big data and mobile telephone companies and what have you not, to see how we can actually get data about these hard to reach populations and get up-to-date data and not the ones that reflected in the last survey 5 years ago, which I think is where Jack started us off.
At the same time, that use of private data, especially, I've seen a couple of studies out there that have used those sort of mobile tracking data, and oftentimes there's this kind of big buzz around machine learning, but oftentimes a lot of people are practicing machine learning in development without really going through the statistical rationale that you really need to when designing those studies. And so definitely responsible use of data, but also making sure the methodologies are in place that you're actually using the data from both the private and public sector correctly, and kind of creating those standards in both academia as well as in the nonprofit and government spaces.
Yeah, I want to shift gears just for a minute here as we wrap up. But Derek, you raised an interesting issue. You pointed out that sometimes health seems like a luxury item to be purchased. How do we avoid or prevent that to create healthier populations both in the United States and around the world?
So I mentioned a bit of it before, and I think that is we have to start creating the mechanisms and the incentives for perpetuating health versus just treating disease, right? You're going to get clinical studies, and for example, a lot in oncology because of the money to be made there. But there isn't money to be made on, say, vitamins or clinical studies on this. So how do you start creating mechanisms that can actually start profiting on the perpetuating health, right? And so I think that's something where we really have to think creatively, and that's where we have to come together with government to create that landscape.
Great insights. I appreciate you sharing that. Jill, let me ask you, as you're thinking about the work that you're doing there at the Cancer Research Institute, what are the collaboration priorities that you see developing? Let me unmute you. There you go.
Yeah, I think that we've seen, especially over the last 5 to 10 years, a lot more collaboration taking place. I think that was something that didn't always happen organically, but I think everyone has come to realize, especially in challenging large diseases, no one can do it on their own. And but collaboration it's a buzzword that everybody says they want to collaborate, but very hard to make it work. You have to find again, it's an incentive program. How do you create something that's a win-win all around? And I think, we have an example at the Cancer Research Institute that we started a clinical strategy where we were originally funding academics to do early phase clinical trials, and they were having difficulty getting access to, non-approved drugs that were owned by pharma, and not being able to ask, investigator-initiated trials in a collaborative and a concerted effort. And so we were able to develop an incentive program with our clinical accelerator that we actually became the not-for-profit broker between the for-profit organizations. We raised a venture philanthropy fund that allowed us to fund these trials. We gained access to drug, but worked in a collaborative way with pharma and the academics to create the protocols and to share that data and to help de-risk. It gives another shot on goal for the pharmaceutical companies that may be not their highest priority, but it's an important, new question to be asked. And if the signal comes out that combinations, and we were able to bring different companies to allow us to bring drugs together, and if there's a signal that this looks like this may be an efficacious combination, the companies then have to bring it on to development, but we get returns on our investment. We don't touch IP, but get multiples in terms of the amount of money that we've put into the trials. So I think this is an example that, everyone talks about how it takes so long to develop a drug and how expensive it is, but part of the expense is due to the many failures that take place at a phase 3 trial. So if we can, as a not-for-profit, create a mechanism where we help to de-risk early, do hardcore, a lot of correlative and translational science to understand mechanistically, even when things fail, why it failed, so that adds value to not bringing things forward into phase 3 trials where there's really not a true understanding of how it's going to work. So, I think that's a win all around for everybody, everyone, and so I think it's collaborations like that of bringing groups together in ways that helps that wins on all sides. Patients win, academics win, for-profit wins. So I think that's the way the collaborative.
I appreciate you sharing those insights. Kurt, I'm going to put the last question to you. One of the things that we sometimes hear people worrying about, and this would be true at Johnson & Johnson and other places as well in business, but that the profits come from treating a disease, not from curing it. And so if we're looking at eradicating disease, how do you invest profitably in the eradication of the disease? You eliminate the need for the products you're selling. How does that work, Kurt?
Yeah, I think you're right. I think that has been the business model of Big Pharma for a long time. It's the ideal situation for generating high revenues, as you alluded to. But you have to go into it with a completely different mindset, and that's one thing that's really unique about our fund is if we generate great financial returns, but we don't generate impact, our investors will be very disappointed. If we generate good impact, but we lose all their money, they'll also be disappointed. So we do need to have both of them there. But we do believe that if we can eradicate a disease and in the process make some money, it doesn't have to be a case where this is something that generates money for years and decades at a time. So we have a different mindset from a traditional pharmaceutical company. We want to get rid of the disease and we want to make some money along the way, but if we get rid of it and no longer make any money, that's actually fantastic. All of our investors would be thrilled. But to your point, we do have a different investor base than most folks, and they value that impact just as much as they value the financial returns. And I'll add to that, but one of the things that has been really rewarding to me is to really open the eyes of entrepreneurs who otherwise wouldn't think about these developing markets around the world. I'm a physician, but I've been in the venture capital world for about 17 years now. And most of that time was spent before I came to the Global Health Investment Fund in traditional funds where we were focused on positive returns. And yeah, we did some good along the way. But one of the frustrating things to me during that time was seeing instances where we had great products that could be used in a resource-limited setting and have tremendous impact. But these venture-backed companies just didn't have the resources or bandwidth even think about, how do you get this over to Africa? How do you get this to Southeast Asia? So they didn't. But what's really refreshing to me is that with the folks who are stakeholders in our fund and people who are involved on various committees, these range from the Gates Committee to folks with vast experience at WHO and other organizations, we can actually show to these entrepreneurs who are developing innovative products that there is a business model that does work, that the volumes that you can sell, granted at lower margins, but the volumes you can sell in the developing world can be tremendous and create a self-sustaining company. And there are many instances where there are these dual market opportunities. And for example, I talked about the cataract company earlier, that, it's really satisfying to see a specific case like that, and there are some others where they weren't even thinking about using that device in a resource-limited setting, and we were able to show them that, hey, there's a need, but there's also a pathway. But you need all of these connections with various organizations, ranging from those I mentioned earlier to ministries of health, et cetera, in order to make that work. So everyone needs to really work together to get the results that we all want.
Devin, go ahead.
On your question, I think there is, if you look at the market for new antibiotics, which we do dearly need as a global community, but we don't want them to oversell, there is the concept of decoupling actually your profit from the volumes. So I think there are mechanisms that can address the problem you raised with your question. However, I'd like to say in my final plug that I think we need systems innovation more than product innovation. 2 out of 3 kids and mothers die unnecessarily because we have the technology and the knowledge and it doesn't reach them. So if you were in private sector, you can't afford to keep your products on the shelf. You need to move them out. So we need market research, we need delivery science and systems innovation. And I think the whole move now towards universal health coverage globally, championed by Dr. Tedros, actually is a great opportunity for us to invest in delivery systems, if you will, to build the roads for these new product innovation cars to drive on, and that we actually become scientific about those downstream things. Over.
Fantastic. Well, I want to thank all of you for taking the time to be with us today. This has been a phenomenal discussion. Incredibly valuable to me. I can't wait to share it and really appreciate your commitment of time. We will link to all of your organizations in the articles and in the book so that people can track you down. And I want to just, again, commend you and thank you for your time and for the work that you're doing.
Thank you, Devin.
Thank you,
Thanks
Devin.
so much for having us.
Great.
Nice to meet you.
Bye-bye.
All righty.
Thanks,
Let's do some
Todd.
Thank you for listening. This podcast was recorded via Google Hangouts on Air and is available at youtube.com/Devin Thorpe. Subscribe to this podcast on Stitcher or iTunes by searching for Your Mark on the World. Every weekday, Devin hosts a CEO, celebrity, entrepreneur, or other changemaker here on the Your Mark on the World show to inspire and prepare you to make your mark. Devin is a champion of social good, writing about, advocating for, and advising people who are doing good. He is a Forbes contributor who is a recognized thought leader in social entrepreneurship, impact investing, and crowdfunding. To book Devin as a speaker, visit devinthorpe.com. Learn more about Devin's work at yourmarkontheworld.com.